Hi everyone, my name is Gurjat Basra and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. I'm very pleased to welcome you all to today's breakout session on cutaneous T-cell lymphoma, also known as CTCL. So just before we start, I do want to go through a few housekeeping items. This Zoom software does not allow you to access chat features or turn on your microphone. So if you do have a question, this session will be followed up by a live Q&A session. So you keep your questions in mind and be sure to attend the cutaneous T-cell lymphoma Q&A afterwards. So to introduce our speaker here today, we have Dr. Meenakshi Taparia, who has completed her training in internal medicine in India and hematology training in Australia and the United Kingdom. She is a clinical professor and has been working at the University of Alberta Hospital since 2006. She has a special interest in rare diseases, including cutaneous lymphomas, histiocytic disorders, mast cell disorders, and Castleman's disease, and she is dedicated to taking care of patients with these diseases. She's been involved in several clinical trials and actively advocates for the availability of treatments for these diseases in Alberta and across Canada. So thank you, Dr. Meenakshi Taparia, for joining us today, and you could get started as soon as you're ready.
Thank you for having me to speak at this program. I'm just going to briefly start about our program and how it works, and then go through the slides for the cutaneous T-cell lymphoma. I am recording this talk on the National Truth and Reconciliation Day. And before I start my presentation, I would like to acknowledge that we are located on Treaty 6 territory, and I respect the histories, languages, and cultures of the First Nations, Métis, and Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. A little about myself, which I've already been introduced, and about the program here in Edmonton. So I started seeing patients with cutaneous T-cell lymphoma about 10 years ago, as I have an interest in rare diseases, and one of our colleagues who had retired or was retiring asked me to take over, and I started seeing patients with this disease particularly. I educated myself with attending cutaneous lymphoma meetings, being part of some of the memberships for cutaneous lymphomas. We did not have a consolidated program until my colleague from dermatology, Dr. Naditsky, who joined the dermatology department with an extensive experience in diagnosing and treating this disease. We then started our multidisciplinary cutaneous lymphoma clinic. We also started a multidisciplinary round every 2 weeks with the pathologist initially in Edmonton, along with radiation oncologists, and started to discuss the pathology and clinical picture and management of these patients. We then also approached the physicians in Calgary with similar interests, and now we have a robust provincial program. And we discuss most of the complex cases at these rounds every 2 weeks. And we have now developed a very good rapport with our colleagues in Calgary, as well as sometimes people from Saskatchewan also join us. So primary cutaneous T-cell lymphoma classification by WHO, which is the 5th edition. We are going to this, as you can see, there's lots of number of cutaneous T-cell lymphomas. The one which we are going to focus today is on mycosis fungoides and its counterpart Sézary syndrome, which is not classified under the cutaneous T-cell lymphoma, but has a separate classification under mature T-cell leukemias. So going through the disease overview, approximately about 75% of the cutaneous lymphomas are T-cell derived, and the rest are B-cell lymphomas. The 2/3 of these T-cell derived lymphomas are mycosis fungoides or Sézary syndrome. The incidence of cutaneous T-cell lymphoma has been increasing and is currently about 6.4 million per million persons. This is based on the surveillance, epidemiology, and end results registry data, with the highest incidence rates being reported among men and African Americans. Black patients with mycosis fungoides have key differences when compared to non-Black patients, including a female predominance, younger age of onset, and inferior outcomes. The cause of this disease is unclear, but there has been some postulation about T-cell receptor activation, altered JAK-STAT signaling, RNA abnormalities, and some epigenetic changes that are found in a lot of research labs that we have more research coming through as common features. Some environmental and occupational exposure to solvents and chemicals have been implicated, but a large case control study failed to support this hypothesis. An infectious etiology for MF was also suggested, but no relation has been confirmed. HTLV1 has been reported in the peripheral blood or cutaneous lesions of some patients with mycosis fungoides. However, an equal number of studies have shown evidence against the role of HTLV1. So what are some of the clinical clues to diagnose a patient with mycosis fungoides? The lesions appear in bathing suit distributions, such as on the buttocks or thighs, or in the sun-protected areas, such as breasts, chest, armpits, and groin. They usually present with patches and plaques of varying size and shapes. These lesions are persistent and progressive, and also they can be association with poikiloderma, which is a combination of hyper and hypopigmented lesions, atrophy of the skin, and some telangiectatic lesions, which is dilated blood vessels. And I'll go through some pictures of different patients of mine in the clinic where we have had a consent from these patients to take their pictures. And some of these patients have been seen by Dr. Robert Naditsky independently in the clinic, and he has shared some pictures with their consent as well with me. So the first picture here, we can see that these are large, thin lesions, which are erythematous, which means they are red lesions, and they are mostly flat on this picture and some hyperpigmentation. Going through the second picture, again, it's in the sun-protected localization, and also in this patient, he had persistence of these lesions. Again, these are thin hyperpigmented lesions. You can also see some erythematous or red patches, and they're well demarcated. These are large. When I say well demarcated, it basically means that the normal skin and the abnormal red skin, you can draw a line in between, and you can definitely delineate the areas in that way. So it means they're well demarcated. This is a picture of a patient with a small patch, which is scaly, and you can see some flaking around the patch. The next picture here is a patient which is more of an erythematous but follicular lesions, meaning they're around the hair follicle area, and they are more papular lesions that we can see. This is a picture where I had talked about poikiloderma, which shows red-brown mottled pigmentation, some telangiectasia, which are these prominent red blood vessels, which are red, and there is some atrophy, which is scarring of the skin and some wrinkling around the skin. And this is present on the chest of this patient with mycosis fungoides. Some other presentation is that of a plaque, which is very commonly seen in our clinic, in our patient population. As you can see, these are more thickened lesions. They vary in size and shape. These are persistent on the patient's body. And there is also some other lesions which are even more thicker, and they appear more like a tumor lesion. This is a hypopigmented patch, and this is seen more in people of color, where we see, instead of erythematous lesions, hypopigmented lesions like you see on this picture, and these are lighter patches, but also patients of color can have erythematous patches or plaques like the other pictures I shared before. This is a picture of a patient in one of the lesions in the armpit area where they have tumor nodules and they are ulcerating in some areas. Some of the other pictures of the variants of mycosis fungoides is that of folliculotropic mycosis fungoides, where you see papules which are erythematous and where the hair follicles arise. These may have a worse prognosis compared to the other regular variant of mycosis fungoides. Some more pictures of the same folliculotropic variant where you see again the follicular lesions on the face as well as some thickened plaques here on this patient's face, and again some more folliculotropic lesions on the face. They can also involve the scalp, and these patients on the scalp can have thicker plaques, also is associated with alopecia as you see in this picture. Next is a group of patients with mycosis fungoides tumors, and you can see these are different size and shape. Some of them are ulcerated. And then there's another picture where one patient has a solitary huge tumor on the scalp, which is large erythematous and areas of which can get infected. This is another patient of ours, which had large tumors with ulceration and um, uh, infected lesions involving the lower extremities. So these are some of the different types of presentations of the patients with mycosis fungoides. Now let's see some pictures of the patients and what Sézary syndrome is. So Sézary syndrome, the diagnostic ICL criteria includes presence of erythroderma, which is basically redness affecting the body, but involves more than an 80% of the body surface area. And they have these lymphocytes, which are called Sézary cells, and these cell count is of more than 1,000 per microliters. And they also have certain changes on the tests we do, which is called as flow cytometry or immunophenotyping. And in these cells, the ratio of the CD4 and 8, which are the type of T cells, is more than 10, or they have loss of T cell surface markers such as CD2, 3, 4, 5, 7, or CD26. And the other criteria is presence of monoclonal TCR population, which is a T cell receptor population in the blood, or abnormality or chromosomal abnormality in the T cell clone. The presentation of these patients is a little different than the patients with mycosis fungoides. As I mentioned, they have erythroderma affecting more than 80% of the body surface area. They can present with alopecia. They may or may not have small lymph nodes, which are palpable, which are lumps and bumps, which we can feel in the neck, armpit, or the groin area. They also can have onychodystrophy, which is basically affecting the nails. They can also have significant palm and feet involvement, which is called palmoplantar hyperkeratosis, and they have significant itching when they present to our clinics. Here are some of the pictures of the patients with Sézary syndrome. As I mentioned, they can have generalized redness to their entire body, which includes their face, could be the scalp, and the rest of the body. Here is a closer look up of the picture of the patient with erythroderma, where you can see faint red rash, which is papular on the abdominal area. The next picture is the picture which is showing involvement of the hands and the nails. You can see the onychodystrophy or destruction of the nails. Again, another closer look to what the nails look like, and also the fingers, where you can see a lot of scaling, dryness, and redness of the fingers. This is a picture of their palms, which you can see the changes on their hands, on the palmar surface, as well as similar to what we saw on the nails as well. It's another patient with Sézary syndrome where you can appreciate the redness on her entire body. So what is some of the differential diagnosis of mycosis fungoides? Patients may be diagnosed with eczema, psoriasis, parapsoriasis, photodermatitis, some kind of drug reaction, or other cutaneous lymphoma before a diagnosis of mycosis fungoides is made. Here are some of the different other diseases that can look similar to mycosis fungoides, hence the diagnosis being made as eczema, psoriasis, a lot of times before a diagnosis of mycosis fungoides is confirmed. In this patient, we can see there is palmoplantar, and the patient was diagnosed with hand eczema, hand and foot eczema. This is a patient where it was diagnosed with chronic eczema, which is a differential diagnosis as well. So this is just a article that was published and shows a histopathologic diagnosis of lymphoma versus other inflammatory erythroderma. And this was based on 47 skin biopsies and published in American Journal of Dermatopathology in 2010. When they did a blind assessment of the stains with H&E, a correct diagnosis of underlying cause of erythroderma was made only in 31% of cases. A correct differential diagnosis between lymphoma and EID was done with certainty in 57% of cases, and multiple biopsies were needed to confirm a diagnosis. Sézary syndrome, misdiagnosed as atopic dermatitis, is very common. These are some of the features of the patients based on this clinical report that was published in 2011. They have long-standing years of skin eczema, and it resembles head and neck dermatitis or widespread dermatitis with itching. They have elevated IgE levels, positive allergy tests. They tend to respond poorly to steroids, phototherapy, and other medications which is used for atopic dermatitis, such as azathioprine. When they fail these, sometimes patients are started on cyclosporin, considering that this is thought to be dermatitis. And when they are started on cyclosporin, they develop a full-blown Sézary syndrome, as we saw in pictures previously where they had significant erythroderma. So the cyclosporin basically makes the disease worse or causes disease progression. And once the cyclosporin is stopped because the disease progressed, there is further disease progression. And then when further investigations are done, monoclonal T-cell population is absent sometimes in the skin in pre-malignant phase. So just showing some of the other pictures, Sézary syndrome can present like dermatitis in this patient. This patient was diagnosed as extensive eczema. This patient had hyperkeratotic hand and feet eczema, which was initially diagnosed with, and then with multiple biopsies, then a diagnosis of Sézary syndrome was made. This patient presented with patch plaque stage MF, but in fact had blood population which was positive, and then was later diagnosed as Sézary syndrome. This patient had leukemic presentation in the blood, but not very common to see this, but had minimal skin changes. So how do we diagnose mycosis fungoides? We know it is very challenging. It can look like various other inflammatory conditions, as I showed you in some of the pictures before. There's no single diagnostic test. It's a rare disease with heterogeneous presentation. It requires both clinical and pathologic correlation, and therefore a referral to subspecialty multidisciplinary program is recommended. There is often a delay in diagnosis, on an average of about 36 months, but it can range from anywhere between 12 to 90 months from symptom to diagnosis. The patients who are seen in these multidisciplinary clinics helps to avoid delay in diagnosis of these patients. Looking through some of the diagnostic tools. So clinical appearance and history, which is the 6 prominent Ps, which is persistent, patches, or plaques. And so these would get 2 points. In the sun-protected skin, which is basically the armpits, groin, the buttocks, the thighs, as well as the axillary area or the breasts. And they can be polymorphic, meaning they all look different in morphology or appearance, and poikiloderma, where I had shown pictures of poikiloderma before. Depending on these features, they get varying points, and I'll go through the next table, which shows how the points and the criteria works. The next criteria is histopathology, which is after taking biopsies and the slides are stained, we see atypical lymphocytes, and it is a prominent epidermal infiltrate that you see. So if you see both atypical lymphocytes with epidermal infiltrate, you get 2 points if both present. These biopsies are also sent for T-cell receptor monoclonality or rearrangements, which is basically trying to see if there is a same clone of the malignant cells present, and that gives us 1 point. These cells are also stained for T-cell markers, and there are 3 different criteria, which is less than 50% of the CD2 or CD3 cells or CD5 cells, or less than 10% are CD7 positive cells, and the epidermal and dermal discordance of CD2, CD3, and CD5 or CD7, which are all T-cell markers, is present. Diagnosis of mycosis fungoides is usually made when a total of 4 points or more is determined. So I'm just going through the table, which basically talks about the same things as the diagnostic tool I just mentioned, but it's in a table format and easier to follow. So you can see there are 2 major criteria, and there are a number of minor criteria. So the major criteria, you have 2 points, and minor is 1 point each. So the major criteria, as I mentioned, persistent progressive patches, thin plaques in the sun-exposed location or different size and shape, and poikiloderma. And any 2 of these clinical gives 2 points. Minor is any one of them. Same with the histopathology. If you have both of the epidermotropism and atypia, then you get 2 major criteria. So, and if you have just one, it can be just either one of them. Molecular, any of this, which is basically clonal T-cell rearrangement studies, and then, as I mentioned, all the T-cell markers, and if there are less than 50% of CD2, 3, 5 T-cells or less than 10% of CD T cells, or discordance between these markers in the epidermis and dermis. In this picture, you can see there's atypical lymphocytes and clusters of these on the epidermal-dermal junction. So what are some of the false statements? Diagnosis is made on the basis of histopathology, which we know is clearly not. We need all these different criteria, which includes clinical criteria as well. A single biopsy should be enough to diagnose mycosis fungoides, and with the next few slides, I'll show you that that is not the case. The diagnosis of MF cannot be made if the biopsy is unspecific. So problems with early diagnosis. This is a retrospective analysis of 157 patients from 2000 to 2010 with confirmed mycosis fungoides. So patients with at least one biopsy, about 157 patients of those were taken. Histopathologic diagnosis of mycosis fungoides was made in 25% of the patients with just the one biopsy. And the rest of them had a histopathology which was unspecific or other than MF, which was about 75% of these 157 patients. Histopathology diagnosis of MF on later biopsy confirmed the diagnosis in about 61% of the patients of these 75%. And histopathologic diagnosis never established in about 39% of the patients. So in about 29% of the patients, the unequivocal histopathologic diagnosis of MF has never been established. So how many biopsies should we take? As you can see in this graph, the more the biopsies are, the higher the chances are that we can make a diagnosis. So with just the first biopsy, only about 25% of the patients are diagnosed with mycosis fungoides. And each consecutive biopsy increases the diagnostic successes by approximately 25%. So time to first biopsy is about 5 patients. In patients with unspecific first biopsy, the median diagnostic delay was about 4.3 years. So the conclusion from this was multiple biopsies are needed to establish the diagnosis in 75% of the patient. Each biopsy has an independent success rate of 25%. Therefore, the patient should be rebiopsied without delay. What I would like to establish is that clinical skills are essential and irreplaceable in the early diagnosis of mycosis fungoides. And therefore, referral to multidisciplinary clinic or care centers where they have expertise would help to make the diagnosis quicker and the delays would be avoided. So let's go through staging of mycosis fungoides. Given that this is a cancer and we know all the cancers are staged mostly, the staging with mycosis fungoides is a little different as it includes the skin staging, the lymph node staging, if it has gone to other organs, which stands for M, which is metastasis, and it can also go in the blood, and therefore, if blood involvement, consider Sézary syndrome. So we'll focus now on the T stage, which is basically a stage from T1 to T4. T1 means that about 10% of the body surface area is covered in patches or plaques. And that's, again, classified as T1A or T1B. T1A is when there's mostly patches, and T1B is when there are plaques. T2 is when 10% or more than 10% of the body is involved with patches or plaques. T3 is when you have tumor involvement, and T4 is when there is erythema, which is redness, and it involves more than 80% of the body surface area. And or lymph node staging is categorized between N0 to N3. M is only M, there's no subclassification to the metastasis, and with the blood, there is B0 to B2, depending on the amount of Sézary cells present in the blood. Now, how do we calculate the body surface area? This can be a bit tricky, but there are some validated tools. And if the patient has few lesions, one can just crudely calculate with the patient's palm or hands itself. One patient hand is about 1% of the body surface area, and the palm area is calculated as 0.5% of the body surface area. But if you have the entire back, if say, for example, then that's considered about 13% of the body surface area. If it's just one thigh, it's about 4.5%. And then you can do a total calculation of the amount of area involved and know the BSA involvement in these patients. There's another way to calculate, which is called MSWAT, which stands for Modified Severity Weighted Assessment Tools. Now, how you calculate this scoring system is a bit different than just the BSA, because the BSA is just total surface involvement. It doesn't put into picture the different types of lesions one patient can have. So a patient can have disease in areas where there's just patches, and some areas there's plaques, and some areas there could be tumors. And therefore, with this tool, you can get an objective assessment of different types of lesions that are present, and the weight is different for the different types of lesions. So it gives an objective assessment, particularly in when clinical trials, which are multi-center trials that are open, then one can have an objective assessment at each clinic visit. So how this works is that the assessment of individual inpatient skin, you have patch, plaque, and tumor lesions, and all the body regions. And then depending on the BSA, you can have, say, 7% patch, 2% plaque, or whatever it is that you have for tumor lesions. So you multiply the patch by a coefficient as 1 of 1. But if they're plaque lesions, the total BSA that you have for plaque lesions involved, you multiply by a coefficient of 2, and for tumor, you multiply by 4. And then you calculate the total score of all of these weighing factors multiplied by weighing factors and get a score. This is definitely helpful in clinical trials, and you can do this scoring at each visit once the patient has started on treatment to see how they have responded to the treatments. So prognosis of mycosis fungoides, as you can see in this graph, this one is a stage 1A and this one is stage 4B. And as you can, and this is graded over years from the diagnosis to up to 30 years. And we know that patch is better than plaque disease, and also stage 1A patients do much better, have an excellent prognosis compared to stage 4B disease. Now, focusing on the treatment of mycosis fungoides, I've just listed all the different treatment options here, which includes topical therapy, light therapy, radiation, chemotherapy, electron beam radiation, bone marrow transplant. We don't know if truly early treatment reduces the risk of progression, and sometimes wait and watch is also a strategy where they have very small lesion and nothing needs to be done. We also don't know if the treatment affects survival, but we do know that aggressive chemotherapy can sometimes shorten survival based on the previous different types of chemotherapy that were given to patients. Now, going through ProCLIPI, which is a study from Cutaneous Lymphoma International Society, where they aim to produce a prognostic index in mycosis fungoides. They prospectively collected clinical, histopathological, molecular, and quality of life data and response to treatments. This opened in 2015, and almost 2,000 patients have been recruited in over 52 centers worldwide. And we can see that patients with early stage disease MF, most patients had skin-directed therapy. So that's the gray bar, and some get systemic therapy in the localized stage 1 disease. But these are patients who have plaque or folliculotropic stage 1 MF, but otherwise most patients just get topical therapy. So how do we treat early stage disease, which is staged as 1A, 1B, and 2A? These are the listed treatments, which is basically initial goal of the therapy is to improve symptoms and quality of life while we avoid toxicity for these patients. For some may involve expectant management, which is just wait and watch. If it's a small lesion, does not bother them, and we can just wait for it to disappear on its own or do nothing as it's not bothering them. But if there are multiple patches, then we can use skin-directed therapy. And steroids is one of the most common ones. The other topical therapies includes topical retinoids such as bexarutin, nitrogen mustard, carmazine, and a newer treatment which is mecloriptamine gel or Ladega gel and imiquimod. Other physical treatments that are used are narrowband UVP, PUVA, and radiation. I'll just go through each one of them with some notable side effects and the efficacy of these treatments and how to use these treatments. Topical corticosteroids is one of the most common early treatment in mycosis fungoides. This can be used in adjunct to other topical and systemic therapies at all stages, and that is the advantage of using steroids. Overall response rate is 94%, with a 30 to 60% complete remissions with the topical corticosteroids in early stage MF. Sustained responses are not seen when you discontinue the therapy, and the toxicity with topical steroids is minimal. So how much to apply is one of the questions we often get asked in the clinics. And the unit that we use is a fingertip unit, which is to use the ointment and apply it and from first crease of the fingertip to the fingertip. And that is 1 FTU unit, which is meant to cover the palm areas, which is about 0.5 to 1% of the area. So how do you estimate in fingertip unit? So fingertip unit is 0.5 grams, which covers about 2% of the body surface area. And so depending on the amount of area that is involved, say if you have a front and back that is to be treated, you need 2 adult hands, so 1 FTU dose. Front of the chest and abdomen, that is 14 adult hands, so which means you need about 7 FTU units. you want to calculate that based so that we know that adequate amount is applied, because a lot of times it is underused and maybe not as effective in that case. Going through some of the other topical agents, we have nitrogen mustard, which is now not available here in Canada. The other ones which we have available is meclorethamine Ledega gel, but it's not available in all provinces or not funded in all provinces. And only if people or patients have private insurance, it may be funded. The response rate with Ledega gel is 70 to 80% in limited stage disease. What we have available is Carmestin, which is about 0.4% similar response rate, but it can only be used with limited stage disease, as if applied to a large area, it can be absorbed systemically and can cause side effects such as cytopenias and other side effects. Local irritation is quite common with Carmestin, but sometimes that can be treated with topical steroids. All of these treatments do take some weeks or months to work, and patients have to be informed about this, that it may take time to work. Bexarotin is 1% topical gel. It's used nightly, not available here in our province, and therefore hard to get this agent, but it's fairly commonly used in some of the European countries. The next treatment, which is used for the early stage disease, is phototherapy. It's an important treatment modality. In patients with limited stage disease, it's narrow band UVB therapy. And the PUVA is where patients take the methoxysorelin tablets along with the ultraviolet treatment. Narrowband is more commonly used, more widely available, and is the modality of choice for both patch and thin plaques. But if you have thicker plaques, maybe PUVA is something that would be better suited for those patients. Phototherapy has demonstrated efficacy in many retrospective and prospective studies. The administration for this, or the dose that is used, vary among institutions. It is started with twice or three times a week. Usually about 20 treatments is used at our centers, and if they have a complete response, they can be lowered to a maintenance dose and then can be stopped if the lesions disappear. How is phototherapy administered? So these patients come to the chambers that look like what it is in the picture, and these body is exposed to light therapy for a few seconds every visit, and they get about 20 to 40 treatments. Typically, eyes and genitalia are protected, as it can cause some long-term side effects on exposure. The aim of the treatment is to get some redness but not having sunburn, and the dose is titrated to achieve that minimal redness. What are some of the side effects from phototherapy? So short-term side effects is redness or erythema, some itching, blistering, and skin dryness. Nausea is reported in patients who take PUVA, which is because of the sorelin tablets. Long-term side effects can be risk of skin cancer and cataracts. Other modality that is used in early stage disease is localized radiation therapy. Can be extremely sensitive to radiation therapy. Adverse effects are minimal and sometimes can cause some erythema and hair loss. Lower dose radiation may have fewer side effects. So this is a summary of the early stage disease. Diagnosis can be challenging, requires clinical suspicion and review of clinical along with histology and other investigations. Management of these patients is skin directed for mostly early stage disease. Just going through some of the other slides now for management of the advanced stage mycosis fungoides and Sézary syndrome. We will discuss here some general approach to the treatments, overview of commonly used treatment, and review some treatments reserved for more challenging cases. The goal of the treatment here is manifold. The first goal is to control disease progression, as we obviously don't want the few lesions to get into widespread disease, which is then harder to manage. To manage the skin symptoms, which is mostly a discomfort from the lesions, itching, and sometimes they get infected and the infections need to be treated. One of the big thing is also to improve the skin appearance, as it definitely improves their quality of life once the skin appearance is better, and people do go through a lot of psychological changes because of the skin appearance. While we're doing all of these treatment, our goal is also to prevent any toxicity from the treatments that we are giving. So the general principle is skin-directed therapy can be used with systemic therapy. It takes about 12 weeks on an average and up to 6 months to achieve a full response. We usually select milder and more tolerable treatments first, and if they work, then we don't have to switch to the other treatments. Can reuse therapies that have worked in the past. Side effects may occur. Most of them are reversible. And if we have any clinical trials, which there is a big need for in these patients, we would recruit these patients on clinical trials when available. So which patients require systemic therapy? So patients with early stage MF who are not responding to the skin-directed therapy, or they have some other variants such as folliculotropic MF, where they have large surface involvement, or some areas where they have large cell transformation. The advanced MF patients, which includes tumor stage MF and advanced stage with lymph node and organ involvement and Sézary syndrome. The different treatments that we have available, let's start with the more milder treatment, which is interferon 2A or Pegasus. This is a long-acting subcutaneous injection. It's done once a week. We usually start at a standard dose of 180. If they are people with small body weights, we may start at a lower dose. And then we assess the response and tolerability, and then either increase or decrease the dose of this treatment. Adverse effects include mood changes, low blood counts, changes to the thyroid function causing hypothyroidism, or some liver function changes. And obviously these patients are monitored to look for any of these changes. Remarkable responses are seen in over half of the patients, mostly with patch and plaque. With tumors, we may not see as much of a response. And it is continued long-term if tolerated and is efficacious. Retinoids, Bexarotin is not Health Canada approved and is very expensive. The way it works is it impedes lymphoma cell growth and causes them to die rapidly. Just listing the side effects includes dry lips, eyes, high triglycerides, liver injury, and it definitely can be teratogenic, and therefore contraception is recommended in these patients. The next group of drug that I would like to briefly touch on is methotrexate. It's inexpensive. It's not very efficacious in mycosis fungoides in our experience. And it works by blocking folate, which is a cell growth factor. And the adverse effects includes mucositis, diarrhea, low blood counts, liver abnormalities. It can be done subcutaneously or orally, and it is done once a week. The next is radiation. It is effective to control single or cluster tumor lesions or plaques. Usually can be used with a lower dose compared to other solid tumors and lymphoma dosing that is used, and can also be used simultaneously with systemic treatments such as interferon or some other chemotherapy drugs as well. Let's go through some of the more newer treatments that we have available in these patients, which includes brentuximab. This is a CD30 antibody drug with conjugate recognized CD30 expressing tumor cells. So some of these cells or patients with the lesions can have CD30 expression, and the antibody conjugates with that and then helps in destroying the CD30 bound tumor. This is given intravenously every 3 weeks, and it can be given up to 1 year or up to 16 treatments. Strong evidence randomized in the randomized Alcanza trial was seen. More than 50% response rates in about 4 months or more. One of the commonest side effects is peripheral neuropathy. The next drug, which is very exciting here in Canada, it is just recently got approved for our patients, and it is an antibody against chemokine CCR4, a marker on lymphoma cells involved in trafficking cells from blood to skin. It's an IV therapy. It's done every 2 weeks and continued as long as skin is responding. The first month of treatment has 4 treatments, which is weekly, but after that, the maintenance treatment is every 2 weeks. It showed very good evidence in Maverick study. Response rate was about 50% of the patients. Patients with blood involvement responded the best, as this marker on lymphoma cells involved in trafficking cells from blood to skin. One has to monitor for skin reactions such as skin rash, which is called mogamulizumab-associated rash, and sometimes is difficult to differentiate between the drug rash and the skin disease from Sézary, and may need biopsies. Once proven it's a drug rash, can be treated with steroids, and you can continue with the medication. The next group of drug is histone deacetylase inhibitors, which is used in some of the other hematologic cancers as well. The two drugs that are in this category is romidepsin, which is no longer available in Canada, but patients who were started on this drug before the drug was out of the market have been getting the medication still on a compassionate basis. The other drug is vorinostat, which is an oral capsule. Funding is very limited across Canada. Response rate is about 25%, and it works by modifying cancer cell proteins and growth. Just briefly touching PD-1 inhibitors, which is pembrolizumab. It's an IV treatment. It is done every 6 weeks, may not be funded. It's a PD-1 inhibitor, which is a type of immunotherapy. It is used in other cancers, both solid and hematologic cancers. It has only phase 2 evidence and no randomized studies in MF or Sézary patients. One has to monitor for inflammation, immune side effects, which affects the liver and the GI tract. Chemotherapy works by stopping cell growth. Cytotoxicity is what it causes, which means it destroys cancer cells along with some of the normal cells, and therefore can cause side effects such as low counts, hair loss, mouth sores. If no other treatments work, we have used chemotherapy, but we typically go with single agent chemotherapy, which is definitely preferred over combination chemotherapy, which has more toxicity and is not any more efficacious. The drugs that we have used in the past is gemcitabine and liposomal doxorubicin. Briefly to mention some of the other treatments, which includes extracorporeal photopheresis. This is a treatment where pooled leukapheresis and plasmapheresis products are exposed to 8-methoxysorelin prior to circulation through 1 millimeter of a disposable cassette exposed to UVA radiation. These irradiated lymphocytes, which approximately are 5% of the blood white cells, are then subsequently reinfused. This causes death of these treated lymphocytes by multiple mechanisms and is very effective in a number of patients, particularly in patients with extensive plaque as well as Sézary syndrome. This has been a first-line treatment in patients with Sézary syndrome in many centers. And it can be used in combination with other treatments such as interferon, and now there are some clinical trials where they are trying to use this in association with mogamulizumab as well. And it can also be used in association with total skin electron beam therapy, which would be my next slide. This is a radiation therapy technique that uses electrons, which are generated by a linear accelerator, to treat the entire skin area. This is indicated for patients with generalized, rapidly progressive thickened plaques. This can induce remissions in patients failing conventional treatments, and it dramatically improves symptoms. The only downside of this treatment is that it's only available, as you can see, in very few centers in Canada. One of them is in Hamilton. The others are in Winnipeg as well as Montreal. And so the patients have to travel and stay there for up to 4 weeks for receiving these treatments, which is definitely not convenient, as well as is expensive if it's not covered in the province. Some of the testimonies that I have had from patients with TSEB and ECP patient is the treatment I had in Calgary with ECP has made a huge difference in my quality of life. My skin is not as itchy and not scaling anymore. However, I wish the treatment was in Edmonton, as is very expensive to drive every other week, and is also very inconvenient, and also have to be in Calgary for a few days. The other patient who went for TACBT treatment in Winnipeg said it was life-changing and wishes was available close to home. This is some of the picture when patients have had TACB treatments and how they have it. This is what the machine looks like, and the standard dose is 30 to 36 gray. Maximum lifetime dose is 70 to 80 grays. There have been some centers where they've tried TACBT with a lower dose of 10 gray, and it still seems to be effective in these patients. Even when this patient had TACB once and then was treated again, and I'll show you pictures of the skin and the remarkable response that the patient had, and they had even tried a lower dose of 10 gray. We have been advocating for getting both ECP and TACB at our centers, but due to resources and funding, it has yet not been possible to get these treatments in our center. So what are some of the challenges in treating CTCL? One, as we know, delay in diagnosis, which is universal. It's a rare cancer, so there are very few centers with expertise to treat these patients. Funding and access is difficult for some therapies. As I mentioned, we do not have ECP in Edmonton, and we have to send our patients to Calgary. And similarly for TACBT, they have to be sent to other provinces. Clinical trials are not readily available to Canadian sites and would be interested in participating if available. We had one clinical trial at our site open a few years ago, and we did recruit patients and would wish to have more clinical trials open in Canadian centers. Specialized treatments such as UVB and PUVA only available in urban centers, and given the Alberta's geography, people come from very further north and south where they don't have treatments available for the simple light treatments, which is very efficacious in early stage disease, and would wish to have more centers open for this therapy. I'd like to conclude by saying that there is a delay in diagnosis. It's a rare and it's complex disease, and we need more access to newer agents and proven agents such as PUVA, ECP, and TACBT. And I thank you very much for me to present at this meeting. And thank you all for your attention.
Thank you, Dr. Taparia, for that very informative presentation. For the audience to have your questions addressed, please be sure to attend the Cutaneous T-cell lymphomas Q&A, which will begin in a few minutes. Thank you and see you there.